see here. Got it. Oh, I got a lot of little prompts that popped up. And you can hear me okay? I have to make sure, yeah, my mute's off because I'm really great at talking with my mute on.
You sound great.
Yeah, thank you. And I am just gonna say I'm really happy that Ryan had mentioned, like, please feel free to jump in and ask questions or interrupt. If y'all have heard me speak before, you already know my vibe is I love it when we just kind of go outside of the norm. Like, don't feel like you have to wait for anything. If you have a question, you just jump in, participate. And if not, if you feel like you don't really want to speak out, please know that the presentation or our interaction does not just stop here. Following any presentation, I will leave my contact information, and you're more than welcome to reach out. And I love, catching up offline with folks who have shared interests or goals. So yeah. Today we are going to chat a little bit about hypertension and the community health worker impact. I'm getting a little toasty. I'm in Star and I'm looking out my window and rain just started pouring down. So it's kind of crazy what weather's doing over here. All right. Well, thank you so much for just ISU for even just having me. Today, like I mentioned, we're going to talk about the impact of community health workers and the impact they have on hypertension. And I'm always super excited to talk about the amazing work that community health workers do. A little bit about myself, as Ryan did already mention. I worked in the healthcare field for about 18 years here in the Treasure Valley in non-clinical roles, started in behavioral health, moved to mental health, and then transitioned over into medical health care. Lots of fun roles, but honestly, like, all of them were definitely just jobs to me until I became a community health worker. I feel like that's when everything changed. That's when I realized that I wanted a career in healthcare. And it was until then that I felt as though what once were like my weaknesses were now my strengths. And I come from what we would call like the underserved and vulnerable communities. And I come from very humble beginnings. I hated that our family had to rely so heavily on resources and assistance just to survive. But I am also extremely grateful and will always remember those who helped us along the way. And many of those folks today would be considered community health workers. Following my work as a community health worker, I became and am now a performance improvement specialist. So what I do today is I oversee the performance of about 80 independent clinics. I cannot tell you how many times I've said to myself, wow, if I knew what I knew, if I knew then what I know now, I could have made such a huge impact. There's a lot of things that as a community health worker, I just didn't know. I didn't know how to communicate to the clinical teams. I didn't know what the clinical teams needed from me to really make a difference in my patients' lives. And community health workers can be game changing if they are equipped with the right tools. I feel like I've made it kind of like a personal mission to teach community health workers, advocate for their work, and help them connect the dots in the healthcare world. So a little overview of what we're going to discuss is overall patient experience, just a really short patient story, stakeholder lens, the provider lens, the CHW lens, the community health worker impact, the community health worker's secret weapon, the lens when it gets blurry, and the mirror when it gets dirty, supporting community health workers and the future of community health workers. And I have to say, this was probably one of the hardest presentations I've had to put together, just because zeroing in on hypertension and like community health workers just really do so much that it's hard to really continuously bring it back to one thing, you know? But I do feel like it's important to kind of get the grand big picture in order to understand just how impactful they are on specific diseases. So One of my most memorable patients, and I'm just going to share a quick story. He was he was assigned to me. He was a diabetic smoker, low income, no transportation. And a little grumpy to start with. I called and would check on him. And, I think it was just probably like maybe the third phone call where he was like, you know what, yeah, I do have a question. And I was able to give him a resource. And then I just continued to just check on him and see how he was doing. And then there was a time when they were giving out some food boxes, and I stopped and picked up some food and asked if I could drop them off, some groceries off for him. And we became, very, our connection became really strong. And so when I went to go drop off the food box and actually visit him and see him, I saw in his home, I was like, wow, there's just so much more here that he's dealing with. He actually wasn't able to read. He wasn't taking his medication. He was experiencing numbness in his toes. His home was very cold. It was, there were a lot of things, a lot of hazards, in his home that I was seeing. And, he didn't know who was who in his care network. And he also couldn't really stand, he had a home health care that would come in and check on him, and he couldn't stand that person that would come check on him either. He was kind of like perturbed by that. But when he saw me, it was like we were buds. He was always happy to see me. He would call me. He text, if he had questions, and I felt like he just kind of confided in me. He was my compadre. He didn't really see me as healthcare. I feel like he just saw me as care. Just caring. So, like I mentioned, in order to really understand the impact community health workers can have on diseases such as hypertension, you really need to know the big picture. So, you know, thinking of the patient experience, but also all the other parts that come into play when we talk about healthcare. Okay. So we're going to talk a little bit about the stakeholder lens. So these are going to be like the payers or insurance companies or the folks that are, these are the people that, our folks, our patients use to be able to afford healthcare services and literally services to survive. Okay. Next, we're going to chat a little bit about, oh no, here we go. Sorry, I didn't know which slide that was. So with those stakeholders, there's different payment models that are connected to how payment is distributed. So there's fee for service, which is basically kind of like you get paid for the services you provide, regardless of the outcome factors. But then there's also the value-based care. So this is value-based care is a form of reimbursement that it ties payment directly to the quality of care that your patients are getting. Okay. So they're literally going to look at like, what are the outcomes? Like, are you going to get paid? Are you doing what you're supposed to do to make sure that your patients are cared for and have a good quality of life? And so that also leads to integrated healthcare. What is integrated healthcare? What is the benefit and who should be involved? Because, when you're really looking at this, it's not just one provider that can do it. It's really a team approach, so you're looking at, a multidisciplinary team structure with value-based care models. So you're going to have probably like a pharmacist, maybe even a social worker, a physician, the primary care physician, the specialist, all those folks that are contributing to the care of one patient. And I really love this image, but if I could remake it, I would put a person standing right next to the patient, and that person would be the community health worker. So payers are heavily guided by entities such as like the NCQA, CMS, and those payers are given a score based on the network of providers that they have. So these national organizations, they really do kind of like guide a lot of the structures and guidelines and policies that the payers have that, fund healthcare, fund clinics, quality incentive programs, and whatnot. So they really look at the quality of care that's being provided. As mentioned earlier, the research and stuff that comes from these entities like NCQA, CMS, et cetera, they've created what is called HEDIS. And what is HEDIS? How is it used? So HEDIS is like a comprehensive set of standardized performance measures, and they're designed to provide purchasers and consumers with information they need to have to be able to compare health plans and the performance to see, like, who performs better, who's actually doing the work, who's going to care about my health. And so some of those measures are outlined here. Like I said, these aren't all of the measures, these are just a few of them, but the clinics are responsible for the patient interaction. Okay. If the clinics don't perform, then they may fall out of a network, which means less clinics and less access to care. And especially, let's think about the rural areas, who have already very little resources, or, little to none as far as clinics. So it's really important that providers are able to provide these services and stay up to date on the needs of their patients. And each year, many of the payers, they select certain measures to score clinics on. And one of those measures are almost always controlling blood pressure, and which is obviously directly related to hypertension. And that measure alone is always marked triple weighted, which means all the other measures, yeah, they'll look at it, but they will look at controlling blood pressure and it's multiplied by 3. So that really makes a huge impact on the score of the clinic. So when we think about the provider lens and how they see things, they're thinking like, wow, I have to make sure that, the quality measures are being covered. There's no gaps in care. I'm capturing all of the diagnoses for the patients. They're providing the medication treatment that the patient needs, and they also have an effective treatment plan in place for their patients. A couple other things that the providers will look at are, when it comes to hypertension, is the hypertension medication. One of those measures on what they're scored on is to make sure that these patients are adhering to their hypertension medication at least 80% of the time that they're supposed to be. If they don't meet this measure, then they don't get paid. If a patient does not get their medication in time, if a patient does not, they're not picking it up from the pharmacy, they may not have access to, then that impacts the provider and their clinics and access to care. The same with the cholesterol medications. 80% of the time, they want to see that that their patients are receiving their medications. Again, if they're not meeting this measure, then they're not going to be compensated for that work. And it's the same with statin therapy for those that have cardiovascular disease. If they don't meet that measure, same thing, they will not get paid, and they could possibly be removed from a payer network. So, and I know that you all have discussed MAP-BP training, and so I'm not going to take a deep dive on that. But I do train our clinics on MAP-BP and how they can take effective blood pressures. It is one of the hardest measures, I feel, for providers, because what we say is that it reopens. So it's like when we say it reopens, it's like we talk about like gaps in care, and that is it, like a controlling blood pressure. If somebody has a blood pressure that's out of control, we're like, oh, that's an open gap. So you can have a patient that all year long, their blood pressure is in control, but the payer, they take the very last reading of the plan year, and that's what they score the provider on. So that is something that really is difficult for providers to keep track of. And typically patients won't call when their blood pressure is controlled, right? They're probably going to call if they're like, whoa, my blood pressure is just kind of out of whack, but it's actually really, really important for patients to continuously communicate with their providers and let them know like how they're doing with their blood pressure, if it's good or if it's bad. They really need to be able to communicate that frequently. And a lot of times community health workers are also able to document that information in an EHR, or even just encourage the patient, to take their blood pressure, or say like, hey, did you call and let your PCP know that you had a controlled blood pressure or where you're at with your blood pressure. But yeah, so that is what the providers are looking at when they're thinking of hypertension. And this is just an example, but they literally get scorecards. So if they are not performing within a certain score, if they're like at a 2-star or then again, they will not be compensated, especially with those quality incentive programs. And for independent clinics, it really does mean a lot. And a lot of the clinics in remote areas, it's pivotal, to them keeping their doors open. So that is kind of like an overview of the provider lens. Okay. But then when we think about our CHWs, they treat the entire patient. Okay. So they connect with the patient to get blood pressure readings. They communicate blood pressure readings to the PCP. They can help to ensure patients are getting their medications in a timely manner. Like, what are those barriers to care? Do they not have transportation? Did they, not switch over their pharmacy, or is there a better pharmacy that's local to them? Can they get this in a mailing? Can they get a 3-month supply of medication rather than having to go in monthly? They're going to really take the time to work with the patient, or even showing patients how to take their blood pressure at home. And again, I'm not going to go into that because I know that's also being covered, but that is kind of the community health worker lens. The community health worker impact, of course, I could just talk about this all day, but a little snippet from NYU. This is from a research study that they did. Patients with hypertension paired with community health workers through their primary care practice were more than 3.5 times as likely to achieve blood pressure control within 6 months compared to patients who were not. Like, that right there is just so extremely heavy and just truly displays the impact of community health workers on just one disease. This it's just the tip of the iceberg of what community health workers can really do. So anyway, I really want to share that little and I know I had mentioned the community health workers' secret weapon, but I feel like the secret weapon is that community health workers, they don't just have the lens. So they're not just looking outward, but they also have the mirror. And I feel like that is what makes community health workers so special. Like, they have the lived experience, they have the emotional intelligence, the time, the empathy, the connection. I feel like it's just kind of like the magic, that they have. Cultural competence and trust. Community health workers are often members of the communities they serve, which enables them to understand the cultural norms, values, beliefs that influence health behaviors and decision making. Their cultural competence fosters trust and rapport with patients, making them more receptive to health interventions and recommendations by building strong relationships with their patients. And so, yeah, community health workers, they can effectively address most of those unique needs and concerns, leading to improved quality of life for patients. And that's one of those large impacts. I feel, how do community health workers impact a patient who might be dealing with hypertension or other ailments? Health, they play a multifaceted role in enhancing patients' quality of life by providing education. They facilitate access to care, managing chronic conditions, offering social support, and advocating for their needs. Through their efforts, community health workers contribute to healthier communities and improved health outcomes for individuals and populations. And going back to the initial patient I was talking about, he had a family, he had children, but they were kind of burnt out. They didn't know resources, they didn't know what to do, and they couldn't connect. But, being able, like myself, I feel like building that rapport and being able to connect is what made the difference in his healthcare journey. The impact community health workers have on providers treating hypertension. So definitely increase patient engagement, being accountable, saying, hey, I'll meet you at this appointment. I would love to go there with you and just kind of process any of the information the provider goes over with you. Med adherence and lifestyle modifications, like, assisting them with their prescriptions and pickups and whatnot, is huge, uh, to providers. Care coordination and referrals, that's also extremely huge. Like knowing who those care team, members are. I know a lot of FQHCs have, different members, like their social workers or their pharmacy staff or, um, care managers. But knowing those folks and not being afraid to reach out and to say, like, hey, I need your help. Can you assist me with this? Can you look into this? And showing that initiative of just, making those connections, monitoring and follow up. Like, I feel the community health workers being able to have patients that they're just checking in on, like I had mentioned earlier, just making those phone calls, say, hey, just checking on you. Hope you're doing okay. Even just shooting a text message, hey, did you pick up your medication? Did you need assistance with that? Um, it's literally somebody who's just kind of coaching them along and holding their hand through a very, very complicated healthcare structure that's not very easy to navigate. And the impact on stakeholders, regarding this, especially the controlling blood pressure triple weighted measure. A lot of times in healthcare, we talk about the triple aim, and that is improved population health, enhancing patient experiences, and reducing overall healthcare costs. So, I mean, there's so many different ways community health workers contribute to this. Um, One being just their overall engagement and their ability to address healthcare disparities, promoting preventative care and encouraging healthy behaviors. They conduct outreach activities, provide health education, facilitate and access uh, healthcare services. They're also key in just overall disease prevention, and management by promoting immunizations or conducting screenings and managing chronic conditions. Their efforts lead to just those just healthier populations overall. So I feel like the work that they do by just connecting the patient to their resources and walking them along the healthcare system so that they can get the care that they have and be more preventative rather than worrying about the intervention, like everything's already happened, is just significant to being able to assist with that triple aim focus. And it's interesting because I feel like, wow, what the payers focus on is also like just right in line with what community health workers focus on. And I will always say community health workers are truly the leaders in healthcare. But when you look at these, it's health outcomes, clinical processes, patient safety, efficient use of healthcare resources, care coordination, patient engagement in their own care, patient perception of their care, population and public health. It covers all of that stuff. And the data alone that's extracted from this is just amazing in what it can do to improving the quality of services provided to patients. So, and with always talking about how amazing CHWs are, I think it's really important also to just chat a little bit about like when the lens gets a little blurry and the mirror gets a little dirty, because ultimately, yeah, I totally think community health workers should be wearing capes anywhere they go because I feel like they're superheroes. But at the same time, like they are human and they have so much, that they're doing that. I feel if you're joining us today and if you're on this call, it's because you care. And so I need to put this in there to protect these folks, and the work that they do. And just ask that you continue supporting the profession. Um, so blurry lens is like how our community health workers may see healthcare. Like they may be really great at connecting resources and connecting to the patient, but is the healthcare system, like, are they given the tools that they need to really understand that? And I feel like community health workers only as good as the tools provided to them, by whoever their, employer is or supervisor. And keeping in mind that when our community health workers are uh, folks who have lived experiences, the best community health workers are oftentimes those who may not have English as their first language. They may not have uh, the level of education that some other folks, have in healthcare. And I feel like that also brings us into thinking about like looking at those hiring processes. The people who connect with folks, it that is alone is so powerful. So looking at that stuff and the requirements, of community health workers and understanding that it's not the norm. This is a totally different role, and it's really about connection and being able to connect to their patients. The dirty mirror challenges is also like after all of that work and like, looking out and the amount of patients and maybe like limited resources, like just considering like the burnout of community health workers, like, are they being, overworked? Do their supervisors know what a community health worker is? Are they becoming like the catch-all? You know, are they given resources and options for self-care? And are they questioning their own capabilities? Like, can I still do this? Am I good enough for this? Am I, when they absolutely are, you know? So I think that those are just really important things that I like to mention when it comes to community health workers is that they do so much and they're constantly working with, maybe vulnerable populations or the underserved, but they also, can be facing their own struggles as well. So supporting these positions, I just can't shout that enough of how important it is to have allies who, advocate for those who are advocating for patients. And I also want to just hype it up even more, but the future of community health workers, again, I know it's the third bullet point, but community health workers are truly the leaders in innovative care. I really believe that. And the future of healthcare is going to require community health workers. And we also have to consider just the overall advancement of technology and the importance of community health workers there. I know that I thought it was so super cool when I had a patient who, English was not her primary language, and I showed her, how to get on my chart and navigate through my chart, and just seeing her being able to have the dignity and the like, independence of being able to sit in the comfort of her home and communicate with her provider about what she needed, but also being able to take her time to, make sure she was articulating what she really wanted to say, and uh not rely on others for that was, it was awesome. It was awesome to see that. So yeah, I feel like that is something that I really wanted to kind of just share and mention about where we're going with community health workers and the importance of supporting those roles and where I'd hope to see them in the future anyway. That's just, I guess, my little 2 cents. But yeah, I wanted to leave a couple minutes for any Q&A. Did anybody have any questions? All right. And also, like I mentioned, if something does pop up later, please feel free to reach out. I'm super happy to go over any of the slides or answer questions or share where I've, get my information from and whatnot.
Maya, if you don't mind putting, oh yeah, you got it. Never mind. I was
Mhm.
gonna say, if you want to just drop that in the chat too, so that way people can copy and paste it and keep it in their contact books.
Yeah.
I
I,
think
I do have a question.
great.
Mike,
Yeah.
would What do you find that you're educating your patients the most on?
Well, I feel like so now I actually educate providers and their clinics. So when I was a community health worker, I think that is the thing, is that I now wish that I knew, then what I know now, because I would have communicated so much more to my patients on. If I could go back and do it over, it definitely would be, I would educate them on preventative care visits and letting them know, like, when they're due for their breast cancer screening, when are they due for colorectal exams, and the different methods. Like, there's not just one method. You could do these other methods. Whatever you do is the right method, just as long as you're being screened, you know. Um, I feel like that stuff is, if I had that information, that would definitely be what I would provide to my patients and educate them on, is that preventative care 100%.
Yeah, I think a lot of times when patients go into doctor's offices, they don't have a good understanding of what questions to ask.
Right,
And part of that is, when am I due for, all these preventative type of things, and
right.
just asking those questions. Awesome
Yeah,
presentation. Thank you.
thank you. Yeah, and that's one thing, is I would encourage also, is write stuff down, write stuff down if you have questions, and take it in there, because I think a lot of my parents, and my dad, he dealt with, hypertension, and he dealt with heart disease, and he had heart attacks, and I think a lot about that, and even what it took for him to go to the doctor's office, like for him having to get up and get dressed, and how exhausting that was, or even my mother who has COPD, thinking about the exhaustion it takes for them to get ready, and and I'm from Montana. So sometimes, you'd have to warm up the car outside in the snow, and, get in the car, go to the doctor's office, having to walk into the doctor's office, and by then they're literally exhausted, and they just want to get through their appointment, and they may have forgotten something. They may not have covered something, with their doctor that they wanted to cover with them, and they just want to go home and get some rest, So I I totally hear you. I hear you, because I think that if they had the information, that's why I think, like, with community health workers, part of their magic is that they know the resources, so they can connect them with those social determinants of health, the things that they need. It's like, yeah, I got you. I can help you with this. Let me do that. They can connect and do that. But they do need to be given the tools of knowing how they can impact their, like, the clinical aspect of things, and the information there that they can provide to their patients and to the clinic, you know, of yeah, what's going on with their patient. So
Yeah, one of the techniques I started doing was I would make two 3x5 cards. I'd make a 3x5 card for myself, and I'd make a 3x5 card for the doctor, which I handed to the person that was checking me in, so that she can pass it off to the doc while I'm being checked in. And here's the
mhm,
list of the questions that I have, so that when they're reviewing your record and looking at the questions, they come in prepared. And it still makes a pretty fast appointment for the doctor, which they're all about, obviously.
mhm.
But it also allows them a little prep time, and you not to forget what questions you would like to ask. So thank you for that. A great presentation. Thank you.
Yeah, absolutely. Thank you.
Awesome. And yeah, Maya, if you don't mind putting your contact information in the chat so that if anyone else has outstanding questions or wants to be in touch with you, they can reach out.
Yeah,
But yes,
absolutely.
thank you. I love how you refer to like the magic of CHWs. I love it. You mentioned that a couple of different times throughout your presentation, and it made me smile every time.
Well, I have to say, like, I think that's why I mentioned that it was, uh, that's when my world changed when I became a community health worker, because all my life it was like, Maya, you talk too much, you're doing a million things at once, or you're not organized, or whatever that may be.
Yeah.
But I was able to, like, I was a people person. I like to connect. I like to talk. I like to be like, oh, do you need this? I got you. And I was finally found like a strength at work, and yeah,
Yeah.
I found that a lot with my community health worker peers too. So
Definitely. And we're excited to now. So thank you so much, Maya, for your presentation. Hear from a couple of community health workers that have some magic in them as well. So I'll just quickly introduce both of them, and we'll turn the time over to Leah and RoseMarie for their part of the afternoon. So RoseMarie Phillips, and she does go by Rose. I double checked with her. She is originally from Michigan, which is fun. I have a son named Lance, named after Lansing, Michigan. So there you go. She loves football and the great outdoors, so I'm sure she had a fun weekend this past weekend. She's worked as a community health worker at Clearwater Valley Health for almost 3 years now, and she has worked in healthcare as a nursing assistant in hospital and nursing care environments for over 15 years. So very experienced with patient care, and she enjoys her community and work, which is a key part of being a CHW. And then Leah, she's also a CHW. She's going on to her 9th year as a CHW with St. Mary's Health in the Clearwater Valley Health. And she's a lead CHW for both facilities and supervises a team of 4. And their program has provided opportunities for her to step out of her comfort zone by leading in that CHW leadership position, presenting and instructing CHW courses as well with us. So we've loved having Leah as one of our instructors. And she enjoys the challenges and changes that the program has to offer, and is excited to see the growth of CHWs in Idaho. So Leah, I'll turn the time over to you to share your screen. And let me cancel mine so it's easier for you. And then we'll just make sure we can hear you both, and then you guys can go ahead and go.
Okay, can you hear me?
You're a little quiet. I'm not sure why.
Is that better?
I mean, I can hear you okay, but if you maybe just speak up, it'll be a little bit more clear. And then if you guys don't mind leaving a couple of minutes at the end for questions and our little evaluation. So
Great, we will do that.
I can't hear her at all.
uh-oh.
Oh,
Oh, that's better.
There you go.
I
Maybe you
just need to lean into it.
There
yeah.
we go.
Yeah.
Does that help?
Yes.
Yep.
Oh, yes.
Okay. All right. I'm going to be up close and personal then here. So we're going to talk about a program that we are piloting right now in our clinics, which is Maya's presentation was definitely a great segue into this, because this is one that we have been doing and hopefully be rolling out to our organization. I guess maybe I should, and Rose, maybe test your microphone too, make sure they can hear
Hi,
you.
everybody. How's it sounding?
Great.
Awesome.
Great. Okay. So what we the objectives is to give you a background on the CoMagin self-management blood pressure collaborative, explain the program as an evidence-based intervention for hypertension control, an economic case for the SMBP programs, and then also how we have structured our program. And then results to date of our program and plans for expanding it out to our clinics. So the initiative, the SMBP initiative, is from July 2023 to July 2024. Our program initially started this with public health. We had a program that they did the same thing, but we would just give the results and things to them. So moving into this program was fairly easy with we had the forms, a lot of the forms, we just had to revamp it a little bit to qualify for this program. But so the goal for this initiative is to reduce the number of patients with a diagnosis of hypertension not controlled, which what Maya was just talking about. You know, we were in helping with those quality measures, and we really succeeded with the organization in helping with the A1Cs and the diabetes. But the hypertension list came, and it was like, "Ooh, that's overwhelming." There was over 1,000 patients, you know, and how are we going to do this? And like Maya said, they go by the last recorded blood pressure and if it was high. So anyway, this new program I think is really going to help our organization. So the implementation team was Laura Knowles and Peg Gearing. They're both providers for our organization, and Alyssa Adams. Can you hear me?
Mhm.
Okay. And Alyssa Adams is our quality measures. Danita Green is a case manager, and me, and then Cody Wilkinson, who is our director of population health. The SMBP collaborative includes a guidebook and resources, which has tons of information and resources. But like I said, we already had a lot of the forms made from the public health program, which they, before we started this one, they ended their program. So it was great. It was just a great segue into this one as well. They also provided us with 21 monitors and cuffs, all calibrated and validated. They have to be, if a patient's going to be part of the program, they have to use one of our cuffs. It can't be one that they have at home if we're going to get refunded or be able to bill for it. We also have bi-monthly meetings with other clinics to exchange their best practices, which is really helpful. Everyone's kind of going about it in a different direction. So it's nice to hear that. And then they also have, and how they're doing it. And then they also, on the opposite months, but bi-weekly or bi-monthly, excuse me, they have the calls that you can call in, and it's just kind of an open, what are you struggling with? If you have any concerns, and you bring that to that meeting and talk through it. And Jenny Lingle is the contact person on that, who's just been really great. So the benefits of the SMBP program with the clinical support has been shown to increase likelihood of treatment intensification, increase adherence to antihypertensive medication, and leads to clinically significant blood pressure reduction. So in our organization, this is kind of our workflow that we have worked out. So this top half here is the providers, and the bottom half here is a community health worker. So the patient comes into their doctor's appointment here, and they may never had high blood pressure, but have a high reading now. So to eliminate that white coat syndrome, or the provider will discuss, you know, you have hypertension. Would you be interested in doing this monitor program? And if they agree to it, I mean, it can be somebody that's taken medication or starting a new medication or changing it up, or for whatever reason, but has hypertension, presents that hypertension at that doctor visit, then the provider will send that referral to the community health worker. In our organization, all the referrals come to me just for tracking. And then you disperse them out to the locations where that patient is. We have community health workers in all of our locations where we have clinics. So the community health worker, oh, I should back up here. In this referral, that provider is going to put all the parameters for that patient. Whether, what's too low for them, what's too high for them, and what are we shooting for? What's our target? And so we'll get that referral. And right here, the community health worker gets it. And they contact the patient and set up an enrollment date. And so once they meet the patient, they'll go through a process and they'll give them the cuff, the education and cuff and stuff. And then weekly, like the first week in that enrollment, they're going to be given a blood pressure log for the week, twice in the morning and twice in the evening. That week, when we get that back from the patient, then we add all of those up, we give an average, and that average is what goes back to the provider, along with the highest diastolic and systolic, and then also the lowest of those two. And then you move to week 2, and the same thing, we're sending those averages in and the highest and the lowest readings. And then the next step here is to go back up. That patient goes back to the provider for a follow-up appointment, which the community health worker has set on that enrollment date with the patient if they don't already have one. And then the provider then will decide, well, do we continue with this program or not? And if no, the cuff gets returned to the community health worker, they clean it, calibrate it, and then they send it on to the next patient. And then if, yes, they do want us to go through, continue with it, this program is a 2-week program. So this goes all the way back. The provider then starts over, sends us a referral that says, yes, we want to continue. And for how long, month or two months, and then we'll continue the same process. They'll continue to get the weekly updates, and so that's how that goes. Let me see if I can, there it is. So when, so Rose has gotten the majority of these referrals that have come in. The provider down in Orfino has just really been on board. So she usually gets a referral with the parameters on it and meets and sets up. So I'm going to give it to Rose, and she can tell you from here what she does when she meets with the patient.
Okay, so I'm gonna walk through the enrollment form, and then the referral questions to the left, I transfer to the enrollment form, and those are all the questions asked of the provider. And so when I transfer that, when I meet with the client, I'll go through this form with them and enroll them into the program. I'm sorry, okay. And so on this form, we start with the instructions for they can understand that they're in agreement to participate in the self-monitoring blood pressure program. And then they agree to take the blood pressure using the monitor provided and record the results as with the provided login sheet. They agreed to report the readings to their provider, and they also agreed to contact the provider if the blood pressure is at a specified too high or too low, according to the provider. And then they agreed to this monitor on the anticipated return they'll bring the monitor back, sorry. And then they agreed that they understand the costs associated with this program and that their insurance will be billed for this. And then we move on to the instructions. When they will record their blood pressure, and they'll either in the morning, evening, or both. And at this time, we're doing 2 in the morning and 2 in the evening. And then they'll take it for approximately 2 weeks. And then we move on to the blood pressure readings, report it, and they'll report those readings, those weekly logs, to the community health worker. And then the same with the returning them. They'll send your community health worker a copy of it, and along with taking it to their doctor when they go to their follow-up. And we'll also make a 3 to 4 week follow-up appointment with the clerks, where they know when to bring everything back and see what the provider wants to do next. And then our equipment, excuse me, I seem to be losing my voice. The equipment, we have a device number, they'll be provided that number and the equipment. And then we'll measure their arm and then determine the size, which is usually a large or an extra large. And then the location, we do it on their left arm. And we'll mark down their anticipated return date. And then after they demonstrate how to use the cuff, we'll write down that initial blood pressure. And then onto our education. There are several forms here and steps in educating the client that we'll show you on the following 3 to 4 slides. And that's also including the video we have. And then we also demonstrate on them on how to use the device and the cuff. And then we have them do it again. So there's a lot of interacting and making sure that they are aware of how to use the cuff. And then we can answer questions after that. And then the final step is we sign in date. And then we can go to the next slide, Leah. And this one gives you options on how to improve your blood pressure. So you're changing your eating habits, getting more physical, getting out there and losing some weight. And then the other one is just the consequences of high blood pressure and what could happen if you don't work on some of these other ideas to the left. There's a stroke, heart failure, heart attack, and things like that. And then the next slide, Leah. This one is a handout on what is high blood pressure, how can you tell if you have it, how can I learn more about it, and then the other one, the article to the right, is this little bit more in depth about what is high blood pressure. And then the next slide, we have the video that we show.
And Sarah, do you think we have enough time? It's probably about a 4 or 5 minute video. Otherwise, we don't need to show it.
It's up to you. It depends how much you have after this.
We-
If we can wrap it up by like 3:25, then I think you'll be fine.
Okay, that's just not.
Right.
But this is a link that you can go to,
Yeah.
and
We'll share it all in an email after. How's that?
perfect. Okay, yeah, that's great. So this is a video that the forms that Rose was talking about are just those hard copies, just that reminds them that they can take with them. But this video covers all of that. Then once when we were talking about reporting to after their 1 week, they go into CPS, and they put in the averages, and this is where I was talking about the highest and the lowest numbers or the enrollment. So this is the form that we fill out. This note goes to the provider. The averages automatically will display on the patient's flow sheet. Results to date, we've had 18 referrals. 4 of them are in progress, 4 on a wait list, and then 10 are completed, 2 declined, which we're hoping we can minimize that number because the provider now is going to ask them instead of if they would want to participate. That way, we won't go through the time and effort if they're not interested at all. 6 of them have completed, 1 dropped, just couldn't figure it out, how to run the cuff. And then we have 1 that's continuing past the 2 weeks. And then rolling it out to the organization, which will be in about a month or so, we're hoping. So first we want to inform the inpatient nursing and the unit secretary, because they may field some calls after hours, because the patients are given those parameters, the highs and the lows, and to call if their blood pressure is higher than this number. And so that's after hours, they're going to be calling the hospital and just to know that those are coming. The same thing with the informing the nursing staff at the clinics, that people may be calling, they may have questions, and this is what this program is. And then informing the providers, letting them know that we have this program, and that just kind of explaining how we do it, and that they're, we know there's a lot of patients that will be needing it, and to be patient as we roll it out. And then also that quality team will be monitoring and reporting out on a periodic basis. We also have to report to, oh gosh, no, I'm drawing a blank. Oh, Co-Imagine. Right now we have 25 cuffs in 2 different sizes and 5 community health workers. So there may be a wait list or wait time, which I'm sure there will be bottlenecked. Rose has already had that happen to her down there. It's just because we had that 1,000 patients it was over 1,000 for the quality measures that they were trying to get blood pressures under control. And I can just imagine what it's going to look like, but we're going to do it and ask for everybody's patience. But I think it'll be a really good thing. So any questions, and here's our contact information, but that's our program right now.
That's awesome. I think it's great. And that program is just so impactful. So I'm excited to see what you're all able to do.
It has been exciting because I feel like it's tied us closer to, or it will tie us closer to the clinics and the providers than what we have had in the past.
Yep.
It looks wonderful.
Definitely not cookie cutter process either. I've found that every one of them is quite different and unique.
Well, and I think also it's truly more accurate also, when they're able to know how to do it on their own from the comfort of their home. They're not, elevated blood pressure, walking into the clinic, just got their weight. The provider or the nurse just took their weight, and now they're taking their blood pressure. And
Right.
so,
Yes. Yes.
Oh, exciting. Thanks for sharing. And if same thing, you guys are, obviously you just shared your contact information. So if any of you, or if you're working in a place where maybe some sort of program similar would be interesting, you can reach out to them and find out a little bit more. So and let's see. Thank you all for your presentations today. I'm going to just share my screen one last time. And if everyone that's been able to participate today doesn't mind quickly filling out this lovely little evaluation, there's a couple of options. You can type in the QR or the URL, or if you can just use your camera and point it at it, you should be able to click on the QR code and open up that link. And we appreciate you all for your participation. The networking portion, I saw a couple people jumped in a little bit later, so welcome. And we're glad you could listen to the presentations with us. And then like I mentioned, if there's any resources that you guys want to request, I will send out an email to the registration list with a link to the recording, as well as the video that Leah wasn't able to share, so that you guys can see that. And then Leah, I don't know if you're willing to share any of those flyers that you shared. I can include those as well, whatever you're willing to share from the presentation.
Oh, yeah, you mean the handouts that we give
Yeah.
the patients?
Mhm.
Yeah, we can do that.
That would be great, just so I can include that for anybody that won't be able to use them in their current position. So
Mhm.
yeah. And once you have that evaluation done, we just wanted to say thanks for attending, and we'll be in touch. Are there any other questions before we leave? I'll be on, but
Thank you all so much.
yeah, thanks. Is that Paul? I
Yes.
just see PZ, so
Oh,
Paul,
yeah, sorry.
I just guessed, I figured. Welcome. And I guess I have my camera off too. Didn't mean to do that. There we are. And then we've got Kara and Jenny over in Weezer, Carla and Barbara. Great group today. So
Thank you. Thanks for having me.
yeah, bye Maya. Thank you so much.
Bye.
Thank you for having us.
Of course. Thanks for taking the time to prepare
Oh, yeah.
the presentation. And it's exciting, like Maya's saying, it's exciting to see that. And I'm very curious over time how when it goes to all of your clinics, how that will improve, the CHW integration into the team, because that's great.
Right.
Yeah, they're hoping the quality measures will improve.
For sure.
Mm-hmm.
Paul's on call. Oh yeah. And once you're done with that evaluation, we appreciate you being here. So
All right, bye.
bye, Rose.
Thank you, everybody.
Bye, Paul.
See you later.
Bye.